Hello and welcome. Thank you all for joining this meeting. I'm Seema Gadia. I'm the Associate Director for Clinical Innovation Adoption at Health Innovation, Oxford and Thames Valley. I'm really pleased that you could all join this session today. We'll just go over a few of the housekeeping requirements. So this session today will be recorded. We've muted everybody so during the presentations. For any questions, if you could add them to the Q&A box, and we've got some co-chairs that will be actually looking through those, and we'll have a session to go through those questions and answers during this session as well. Within the quick Q&A section, there's an arrow you can use to upvote questions. So if somebody has already asked your question, you can just click on that and it will prioritize that. So we make sure we get the ones that you want answered during the session. So if we go on to the agenda, thanks. So I'll just give an overview of the programme and the impact we've had so far. It's been a 3-year programme. It's been a great programme, loads of interaction, networking and engagement from systems. So you'll be able to see some of those results. And then we really wanted to shine a light and spotlight on some of these quality improvement initiatives that have been carried out at PCN and practice level. Some absolutely great projects. It shows the passion of people delivering some of this work. We've grouped the presentations into 2 themes. One is under education and training. So they're from people that have attended our education and training and looking at what they've gone back to practice to deliver. And the second group is one of the aspects of our programme was to focus on public behaviour change, and we introduced some materials to support with that. And so other quality improvement initiatives have actually focused on implementing those, so we'll hear about those as well. After each block of presentations, we'll open up the Q&A sessions where you can ask any questions to the 4 previous presenters. Those Q&A sessions will be facilitated, the first one by Gillian and the second by Sundus. If we go on to the next one, please, Mariana. So, this programme started in April 2022. A lot of you on the call have been involved in this programme. It was comprised of 3 pillars, and underpinning that there was a community of practice which actually held everything together. So we had these communities of practice and 3 pillars. It was a national programme, so there's lots of areas across the country that were actually working on this. For the communities of practice, we've been very lucky. We've had communities of practices run in all of the 3 ICBs that we've supported, and we've had great chairs for those communities of practice. So in Frimley, Sundus and Dr. Melanie Wright chaired the groups. In Bob, Brendan and Dr. Rebecca Bowers chaired the groups, and in BLMK, Tess and Omas chaired the groups. With regards to the pillars, the first pillar was focused on the NHS BSA polypharmacy comparators and understanding the data that underpins problematic polypharmacy. The second pillar was focused on education and training. So at a national level, there was action learning sets delivered. And as part of that, we supported people locally to become accredited trainers to deliver training. So then they went on in the second year to deliver bespoke training to local systems. So we've got 4 local accredited trainers in our area: Sundus, Hannah, Nixit and Rena. So we're very grateful to them, and they've delivered some great work in some of those bespoke sessions, which many of you may have attended. For the public behaviour change, that was a campaign to introduce some public-facing materials to engage with the public with their SMRs, and so patients can come prepared for their medication review. We had a couple of test sites before we actually launched the material, and those materials were tested in Hatter's PCN and Remead Medical Practice, so thank you to them as well. So if we go on to the next slide, all of that activity has resulted in this incredible impact. So this slide just reflects some of the numbers that we've had. So understanding the data webinars, we've had 71 people attending. The action learning sets, as mentioned, we've got 4 accredited trainers and 97 prescribers have attended those from our area. And the Pillar 3, there have been numerous downloads of the material. With the communities of practice, in total, we've had 20 communities of practice across our region, 670 people attending. And as I mentioned earlier, the accredited trainers have gone on to deliver bespoke polypharmacy sessions, and we were able to host 11 bespoke sessions and have had over 500 people attend those. But what this session focuses on, and we want to share, is some of this quality improvement work that has been done as part of this program, because it's one thing to train people and to spread this material, but it's what happens with that in practice and how it's implemented, how it's used. So in June last year, there was an expression of interest launched at a national level and a local level to support sites to deliver quality improvement initiatives. So there's a small amount of funding available to actually act as a catalyst for that. And at a national level, 27 quality improvement initiatives were run. Eight of those were within our HIN geography, and that's who we'll be hearing from today. So if we just go on to the next slide. And this is just an overview of those 27 projects that were spread across the country, and there's such a range of different areas that people focused on. So some identified age, some looked at housebound patients, some specifically focused on those seldom heard communities, some focused on particular areas like anticholinergic burden or acute kidney injury. So a whole range of quality improvement initiatives were actually delivered. If we go on to the next slide, please. Within our area, we've been really lucky that we've had 8 quality improvement initiatives from really passionate teams. I'm sure beyond these, there's loads of you also delivering these quality improvement initiatives. We were able to fund 8, and all 8 have produced reports and collated all of their learning, which we want to share today. So we've been lucky today that we've got leads from each of these sites and each of these projects to actually present their work. And again, as you can see, it focuses on a whole range of areas. So antidepressant prescribing, anticholinergic burden, acute kidney injury, and actually reaching out to those communities as well that are maybe a bit more difficult to who find it harder to engage with healthcare services. So if we just move on to the next slide, please. So I'll introduce each one. So you'll hear from the first 4 presenters and their projects, and then we'll open up for a Q&A session. So I'm going to hand you over now to Sunny from Nora PCN, who will talk about their antidepressant reduction project. Sunny, over to you.
Thank you. So hello, everyone. I'm excited to share a summary of our deprescribing project conducted across 5 GP surgeries in Oxfordshire. The aim was to reduce unnecessary long-term use of antidepressants through a targeted clinical pharmacist-led intervention. We partnered with the Health Innovation Network to explore how a structured primary care approach could address this issue safely and effectively. Our work was inspired by a successful 2023 project led by the Rotherham Medicines Management team, and they achieved excellent results using outreach specialist mental health pharmacists from secondary care. Their model showed that a structured deprescribing is possible and impactful. We asked ourselves, could we replicate those results using a different workforce? Specifically, could we achieve similar outcomes using clinicians already embedded in primary care, like our clinical pharmacists? The question became the foundation of our project. Next slide, please. With our goal clearly set over 4 months, our aim was to review 10% of eligible patients and support 60% to stop and 40% to reduce their antidepressant dose where appropriate. In our network, patients already have annual medication reviews, but we noticed that conversations around deprescribing were often reactive and led by the patient, not always planned or proactive. So we wanted to change that. We focused on patients over 22 who had been on a first-line antidepressant for 2 years or more. Using EMIS, we ran searches across our 48,000 strong population and checked every patient to make sure they met the criteria, excluding those with active secondary mental health care. We reached out using AccuRx, with some practices offering self-booking links. Where that wasn't possible, our pharmacy team picked up the phone. PHQ-9 questionnaires were sent ahead of appointments or completed during the initial appointment if needed. We supported patients throughout, talking through what to expect, looking out for withdrawal or relapse, and agreeing follow-ups at 1 to 2, 4 to 6, and 8 to 12 weeks. At the end, we sent a short feedback survey to patients. Next slide, please. So over the course of the project, we invited 1,791 patients to take part. Our response rate was 6.9%, which was really reassuring. It closely mirrors the 8.2% achieved in the original Rotherham case study. Among those who engaged with the service, 11% were able to stop their antidepressants entirely, and over 65% reduced their dose. So a fantastic result for both patients and clinicians. What really stood out was how much variation we saw between practices. Surgeries that required patients to call in and book manually saw a much lower uptake, so just 1% and 3% in some cases, which tells us that having to take that extra step can really discourage engagement unless the patient is already highly motivated. In contrast, practices that used a self-booking system saw far better results, not just in uptake, but in pharmacist involvement. Next slide, please. So this graph shows a breakdown of the patients who stopped their antidepressants during the program, and more importantly, who supported them to do so. The orange bar represents the total number of patients who stopped their medication across each practice. The blue segment within that shows the number who stopped specifically due to structured, clinical pharmacist interventions, so those who were supported directly through our deprescribing clinics. And the brown segment reflects those who stopped outside of our intervention, either on their own or through potentially GP appointments. What's really interesting here is a clear trend. Practices that adopted a self-booking system saw a much higher proportion of pharmacist-led deprescribing. And what's also encouraging is that 182 additional patients chose to stop their antidepressants independently during the same period. And that tells us that we're seeing the start of a cultural shift where both patients and clinicians are beginning to feel more confident about reviewing and, where appropriate, reducing long-term antidepressant use. Next slide, please. So one of the big lessons we took away from the project was just how important access and experience are when it comes to engaging patients in deprescribing. Firstly, reducing access barriers made a real difference. When we offered self-booking links, patients were more likely to engage compared to traditional phone-based systems. That system gave us more control over the review process, made it easier for patients to engage, and ultimately allowed us to support them better through the entire journey. Secondly, we saw that clinician experience really mattered. Our more senior pharmacists achieved noticeably higher deprescribing rates. That's not surprising. They're more confident having those complex conversations, but it also shows there's a real opportunity to mentor and support our junior colleagues to build those same skills. And finally, one of the most meaningful changes is that deprescribing conversations are now becoming routine. They're not just one-off interventions, they're being built into our regular medication reviews, which helps us align with NICE best practices and make these conversations feel normal, expected, and safe for both patients and clinicians. Next slide, please. So as a next step, we're planning a 6-month follow-up to continue supporting patients on their deprescribing journey and evaluate long-term outcomes. We'll also be expanding the use of the self-booking links in future projects because we've seen how much they boost participation and make access easier for patients. To support our clinical teams, we'll be delivering education sessions across member practices, reinforcing the updated NICE and Royal College of Psychiatrists guidance and helping clinicians feel more confident in these conversations. By refining our processes and sharing what we've learned, our aim is to scale up deprescribing work and continue improving patient-centered mental health care across the PCN. And beyond antidepressants, this project has shown us that the same structured, proactive approach could be used to safely address other dependence-forming medicines, for example, opioids, benzodiazepines, Z-drugs, and gabapentinoids, opening the door to a wider medicine optimisation work across primary care. Thank you.
Thank you, Sunny, and that was a great piece of work. It's really interesting to hear about how you've addressed the access issues, and that came out in your key learning, that improving patient access to the reviews was one of the key things to increasing your uptake rate. So it'd be really interesting. I don't know if you could post in the Q&A session about how you or we could discuss it actually in the Q&A session about how you set up those self-booking links. Please do post any questions you have about this project in the Q&A session, and we can actually now move on to the next project as well while you're putting in your questions. The next project is led by Kavita, and that's around reducing anticholinergic burden in care homes.
Thanks, Ema. Yeah, so my name's Kavita. I'm the lead clinical pharmacist for Hatters. The other person that did the patient reviews with myself was Priyanka, who's unfortunately not able to attend today. So through this presentation, I'd just like to give you a bit of an overview, some of the outcomes, lessons learned, and sustainability around it. So for the project overview itself, if we can go to the next slide, please. Okay, so what we realized was that, first of all, like, patients who are in nursing homes and care home residents, they have a mix of, sometimes they're not able to take decisions in their best interests. They're often vulnerable, so they get left behind. They don't get the same amount of input as patients do who can come into surgeries. And often the ACB score is a big risk factor to falls, confusion, cognitive decline, and etc. So that was one of the things that we wanted to review, and we sort of called it reduce my burden because off the back of that we reviewed other things as well. So we reviewed things like pill burden in general. So let's say if somebody is taking 2 times 40 milligram atorvastatin rather than 1 times 80, just deprescribing in general, so polypharmacy, and also high risk medication, because sometimes these patients, they don't eat and drink well, so if they're taking ibuprofen or something like that, they're at risk of AKI. So we essentially then ended up looking at quite a lot of things. So what our intervention was, it was pharmacy-led medication reviews in 6 care homes across our PCN. We found patients with the highest ACB score, so that's what we used as our search criteria. And then we went out to the nursing homes and we educated them about anticholinergic burden and what that means. We gave them a resource, a patient resource. Unfortunately, I couldn't find like a general NHS one or one linked to the ICB. So we found a really nice one, which was done by Swindon and Bath, and it had almost like a pictogram of a person with like different arrows pointing out and saying, oh, you know what, the cognitive burden can have an effect on their urinary tract. It can also affect their brain, etc., etc. So it kind of was a nice picture for all the nurses and the care staff to understand. And then we worked with the GPs as well to essentially deprescribe, so do the reviews and deprescribe. We had a direct chat with the patients who were able to, as many as possible. If not, we got the residents and the care homes involved, and it was good because they then had an understanding about their patients and also their relatives and their medications. So what we found as the general outcomes, if we could go to the next slide, please. So we did 27 patients, like I said, with individuals with and without capacity. The anticholinergic burden was reduced for 5 patients, and the pill burden was reduced for 10 patients. And overall, the number of medications were reduced for 10 patients. So that was quite good. And also high risk medications were stopped for 8 patients. So we thought that was quite significant in terms of the overall outcome. We also had some really good patient and staff feedback. So one of our patients was quite funny. He actually thought that we were there to review him because it was a cost-cutting theme, as he put it, and he was actually very pleased with it at the end because he said he felt better, he felt happy that he was on fewer tablets. So for us, that was like a big achievement as well. So that was one of the patients that did have capacity. And the staff found the training quite useful. It gave them insight into the patients, and they know more about anticholinergic burden. So some of them have said that actually since the training they've received, they've been able to raise any potential issues that they feel may be medication linked back to the GP in certain cases. So yeah, that was nice for us and also for the patients. In terms of the lessons generally, so the next slide, please. Yeah, so not all patients with polypharmacy had high ACB scores. Some people just have high ACB scores on its own. And often they're linked to various medications, but a lot of the time they could be mental health medications. So what we found was that anything that we thought we may not be quite competent to review, we could, since then we've started to engage the mental health pharmacists that are linked within our area. So they actually get quite a few emails from us now, and we're able to do something about the patients together. So sometimes we might get advice, sometimes they might be seen by the specialist. And we also realized that actually carers who are so integral to reviewing, you know, they look after these patients all the time. So it's good to get them involved and provide a bit of training, even if it's just short sessions or some few helpful resources for care homes around these things so that they're able to refer back. And yeah, a lot of different staff found that helpful as well. We also had like an Excel spreadsheet for the data collection, which tied in quite nicely with the standard, like the general medication and polypharmacy review template. So that was quite helpful. And in terms of sustainability, if we look at the next slide, please. Yeah, so like I said, we're already doing more work around this and we're getting mental health pharmacists involved as well. In terms of the spreadsheet, we've expanded it so that it covers mobility, falls, consideration of bone protection as well. So that's both the bisphosphonate and Thiacal. So whether that's suitable, so that's something that we've extended. And just discussing these patients in our regular kind of clinical meetings and things like that tends to help. So one thing that we didn't quite, we sort of got like, free text feedback from patients and staff, but having like a standardized questionnaire which they're able to rate things from, that's something that we kind of thought in hindsight, actually. So that's something that we think we would do next time as well. So I guess ultimately we learned that there was quite a lot to think about for us as clinicians and as pharmacists, the doctors being involved as well, especially when it comes to certain high risk medications. And the patients found that this was like, they actually thought this was a good improvement for them, and also good feedback from the relatives as well, because they were just happier that their parents or grandparents, whoever, just had to take less medication. So overall, we found that this was quite a useful project for us to do. Thank you.
Thank you so much, Kavita. And I know you've moved on to a new role, so thank you very much for coming back to present your work. With this one, it's really interesting to see how you've trained care home staff to be more aware of some of the symptoms that may present with anticholinergic burden. So I think that's like you've spread the word to a wider team so they can be alert to, okay, this could be as a result of anticholinergic burden. So I think that's great, and that will support sustainability, because now they know that, oh, if a person feels quite tired, it may be due to that. So great work. And that networking you've sort of built in with other teams like your mental health teams, again, that's great to see within this project. And it is always nice to see all the knock-on effects, that you're originally going to do one thing, but you end up doing quite a lot of broad other things as well. So thank you, Kavita. Any questions for Kavita, please do add them to the chat, and Jill will facilitate the Q&A after the next two sessions. So if we move on now, Sally's kindly going to present this quality improvement project. Again, this is an educational intervention. This is focused towards the pharmacy team, and again, it's around anticholinergic burden. Sally, if I just hand over to you.
Thank you, Seema. And yeah, very interesting to hear Kavita's presentation, and there's lots of similarities in how we approached this. Obviously, both projects looking at anticholinergic burden. So my name's Sally Arneson. I'm a lead clinical pharmacist at Berkshire Primary Care, a GP federation covering 2 PCNs. I'm actually a super sub today. Emily, my colleague who led on both of our QI initiatives, is on a plane at this moment on her way to Spain. And as I'm firmly sitting in Bracknell today, I got presenting rights. So my apologies initially if I misrepresent anything that Emily has said. So Emily attended the Action Learning Set events early in 2024, and inspired by that, she wanted to come back to base. And within our team, we have 16 pharmacists and pharmacy technicians, and see how she could spread that learning to pharmacy professionals who could not yet attend the Action Learning Sets. Next slide, please. So the intervention that Emily wanted to do, was to upskill the pharmacy team to be able to better tackle anticholinergic burden as part of structured medication reviews. And the way she chose to do that was to undertake a masterclass. We have protected learning time for the pharmacy team every month, and she wanted to deliver an anticholinergic burden masterclass to the whole team and measure several things. So firstly, an improvement in confidence and competence of the pharmacy team before and after the masterclass, and then trying to measure the impact that had on structured medication reviews in focusing on anticholinergic burden score. Next slide, next slide, please. Thank you. So we were able to measure outcomes in 3 areas, and in the first, in the questionnaires that were done before and after the masterclass, there was a shift, a definite shift in terms of staff confidence in addressing anticholinergic burden medications, and also being able to approach SMRs around ACB in a structured way. So both confidence and competence were shown to increase. When we looked at data, part of the intervention that we did was to break down our structured medication reviews into two parts: a sort of pre-SMR, where ACB was scored by pharmacy technicians. And one of our problems is it's hard to intervene in ACB if it's not being scored regularly. So one of our outcome measures was to look at whether ACB scores were more regularly being documented, and we were able to demonstrate in the before and after an increase by 60% of ACB score documentation from the samples that were taken. And probably more significantly for patients, there was an outcome, there was a reduction. It wasn't as great as the ones that we saw in previous projects, but there was an average ACB score reduction from 3.7 to 2.3. And as you know, every reduction is important. Next slide, please. Moving on to the lessons learned. So I think probably the biggest lessons learned for the team was how to tackle this. And as Kavita highlighted previously, there's a real lack of sort of guideline-driven approach to this. We all know that ACB drugs are bad, but in terms of approaching how to de-prescribe them, there's not much hard and fast guidelines. So I think the lessons learned were we got a really good structured approach from Emily as to how to approach the conversations, how to explain what ACB score is, and then how to tackle reducing and de-prescribing in a planned and proactive way with some shared decision making in there. As a knock-on effect of this, I think we learned some lessons around patient engagement and how to tackle and explain what ACB is, and then how to sort of de-prescribe it. Seema, you mentioned the unintended consequences, and I think there were lots of other, having a focus in one area helps us to improve SMRs altogether. But I think, next slide, please. Like any of these QI projects, there are always lots and lots of next steps, and these things grow arms and legs, which is what we always want with this. And so our next steps, we often have pharmacy students working with us. And two of our pharmacy students who were with us at this time produced a leaflet, which you can see on the screen there. It needs a little bit of tweaking, but we felt that was a really good start. And we've used this since in terms of educating our own care home teams. We've shared it more widely with practice teams via a newsletter. And I think there's a continued focus on anticholinergic burdens. I think the biggest challenge, and maybe this will come up in the Q&A in a little while, is how we stop throwing the bodies into the water. I feel that we're doing a lot of pulling the bodies in downstream, but if we could encourage and educate our GP colleagues to not initiate the drugs in the first place, so stop throwing the bodies in, then we wouldn't have to keep pulling them out further downstream. So perhaps we can have a bit of a discussion about that. But like any of these things, there are lots of next steps, and this resource is available for you to adapt and adopt as you wish. Thank you very much.
Oh, thank you very much, Sally, and I love that leaflet. It's I'm sure it'd be useful for a lot of other areas as well, and it's a nice centerpiece to have a conversation with patients about anticholinergic burden. Otherwise, it's kind of hard to explain it and what the consequences are. I also like how you've sort of used all your team members, all your pharmacy team members, so your students, your technicians, and so everybody's really got engaged with this work, and so well done on that. So any questions for Sally, again, put them in the Q&A, and we'll move on to Nixit. Nixit has done his project around frailty and polypharmacy reviews in high-risk patients. So handing over to you, Nixit.
Hi there, everyone. My name's Nixit. I'm a pharmacist. I've been in BLMK for many years now in practice. So I also lead for the East Bedford DCN, and also I'm a local polypharmacy trainer. So I've done quite a bit of work around polypharmacy in the past. We wanted to go and do something different this time. So we tried to amalgamate a lot of the ideas that the previous people have done and try and put them together and really try and re-stratify and look for those high-risk patients. So this is a PCN-wide project with 4 practices, and the idea was it was done by myself, and I worked on the 3 other practices, and my colleague Runil worked on one of the other surgeries in the practice. Next slide, please. So in terms of the project aim, we really wanted to first and foremost focus on high-risk patients. So because of these patients were quite high risk, we really wanted to focus on patient safety. Kind of patients that we were picking up were patients over the age of 75 with moderate to severe frailty, as well as a lot of these patients have had 3 or more hospital admissions in the last 12 months. So this kind of helped to narrow it down using the Eclipse software to narrow down the searches. And really the main issue was around how do we prevent from our side in minimizing those hospital admissions first and foremost. As part of that, in terms of reducing risk, we focused on reducing anticholinergic burden. There's a lot of drive. Pharmacists love anticholinergic burden. We send to, it's really good that we go home on about this because, you know, more and more colleagues are aware of it now as well. So that's really good. But it wasn't just polypharmacy medications. It wasn't just anticholinergic medication. We also focused on high-risk medication. So we call them the DAM drugs. There's a reason why we call them DAM, because for the moderate and severe frail patients, the diuretics, the the non-steroidal anti-inflammatories, the antiplatelets, metformin are often associated with lactic acidosis. These are the patients we focused on to try and reduce the risk of that. Patients, having necessary falls or hospital admissions for both that. And thirdly, a lot of the colleagues, the other 2 colleagues that I work with, they hadn't done the polypharmacy training. So the idea was to empower more colleagues and try and get them involved so that we can try and make this project sustainable. So as part of the project, as I explained, we re-stratified patients. So we picked up patients with severe or moderate frailty over the age of 75, taking at least 10 or more medications. And some of them may have had 3 or more hospital admissions in the last 12 months. We reviewed the process. That was a huge list. We had over 75 different patients from, we're a PCN size of 53,000 patients. So, and then we had to re-stratify. So originally our plan was to only review 20 patients, but we realized that was an impossible task. So we doubled that to go up to 40 patients. And then we did a level 2 medication review, so a 15-minute desktop exercise to assess patients, the list of medications they were taking, the current conditions, the reasons why they were, getting to hospitals. Was there a trend there? Was there a reason why they were getting into hospital admissions? And then we invited these patients onto a 30-minute face-to-face structured polypharmacy review and used tools like GP evidence because, of course, we don't have many guidelines in terms of de-prescribing. So, evidence-based data kind of helps. So GP evidence works really well. And we used a stop-start toolkit as well. Beyond focusing, as I explained, it wasn't just about anticholinergic burden, it was the other high-risk medications. But we also took that further, and it wasn't just about those high-risk medications. We also looked at other high-risk medications like psychotropics. And like a lot of the cases, we always tend to do more as pharmacists. So naturally, the inclination was how can we raise awareness of this as well to the rest of our colleagues as well. We collected the data over a spreadsheet, and essentially the key focus was around making sure that polypharmacy is not compromising safety. So it's not one of the reasons why people end up in hospital. We also wanted to empower patients. We wanted to make sure that they understand why they're taking the medications and make them involved, try and get them involved as much as possible in making decisions. We know enough evidence that over the age of 75, I think the evidence is like 67% of people feel that they take far too many medications. So empowering them and getting them involved was probably very important to make sure that they're involved in those decision making, especially with some of the medications where we don't necessarily have guidelines. So the easier thing is to not touch it and leave the status quo rather than challenging why they still need that medication. And again, as I mentioned earlier, so it wasn't just about those other high-risk medications, but again, some of those high-risk cardiovascular medications, the antiplatelets and the the DOACs as well. So next slide, please. So in terms of the results from the project outcome, we managed to get 33% reduction of anticholinergic burden. So around 36 points were reduced from our 36 patients. So I think some of them didn't attend, some of them went in hospital at that time. So that was the reasons why. We managed to stop numerous medications, amitriptyline, solifenacin. Some patients we even managed to reduce isosorbide mononitrate. 1 or 2 patients were on like other older antidepressants like fluoxetine. We managed to reduce those as well. In terms of inappropriate medication stopped, we managed to reduce 14.5%. Essentially 75 medications were stopped from 36 patients. So I think the 75 probably sounds a lot more rather than the percentage. Statins, aspirin, dihydrocodeine in patients, where it wasn't required. We managed to stop a lot of inappropriate medication on that point of view. We're already aware of the anticholinergic burden and the risk of falls that we had with that as well. So next slide, please. So in terms of, just wanted to share some of the case studies and highlight the complexities of not only the project, but also how we plan one thing and how far it can move on. So the first case study was a patient who turned up in the surgery, had a mild learning disability. He turned up 2 hours early in the practice. He was pacing around the surgery. His clothes were stained with feces and urine. He hadn't washed himself for many days. When I got him in, my colleague in the next room could even smell, the stench that was coming through. And when we started discussing about his medications, and we realized, he had very high blood pressure, 190 or 111. A lot of his medications hadn't been issued for the last 4 months. This sort of escalated into creating a safeguarding issue, working with the care agency. I had the learning. We had a learning disability care coordinator as well as a learning disability lead involved in the process. This led to an investigation. Multiple follow-up appointments were done to ensure that he was taking the medications. Again, from the social side of things, he was getting the daily washes, his clothes were getting washed regularly. All of those extra support that was needed to be put in place was put in place for him. And towards the end, I just checked a couple of weeks back, his blood pressure is finally coming around to a reasonable level. And in the process, we managed to remove certain medications like tolteridone, which hadn't been issued for months and it wasn't working for him. He wasn't even keen on taking them. So again, focus on reducing that anticholinergic burden. A second case was actually a complex rheumatology case. So again, we were reviewing this patient. We found out that they had the recent LFTs were massively abnormal. And we managed to write to the rheumatology team to say, and we withheld the methotrexate. In the process of doing the review, we found out they'd been on alendronic acid for 12 years. Again, the evidence of alendronic acid over 10 years increases the risk of atypical femur fractures. So as part of that review with rheumatology, they managed to, because we highlighted the issue, they managed to switch him over to Prolia. He was on high doses of opioids, or he was on high doses of morphine. So we had a discussion with him, and he was still in a lot of pain. So we explained to him about the lack of evidence around management of chronic pain with high dose opioids. We had a local PCN management service that was CBT based. So again, we tried to utilize the wider professional network to try and work together to try and support him. And in the process, we've had a few other appointments thereafter and starting to reduce his morphine dose. And the third patient, this was with one of my other practice. The gentleman had CKD4 with worsening macular degeneration with very poor eyesight to the point where he was needing to use a magnifying glass to be able to see things. He was on 22 different medications. He was really struggling to take his medications. We did a full review with him, had a discussion. We managed to bring it down from 22 down to 16 medication. This was he had CKD4 and he was on a modified release dihydrocodeine, so that was the patient. We managed to stop a lot of these medication. We contacted a few local pharmacies, and one of them was willing to prepare a dosage box for him. So we managed to put him on a dosage box with them, not only reduces safety, reduces risk of ending up in the hospital because of medication issues, improved his adherence with medication, and also removed inappropriate medication. So I felt that we served our purpose. We did the patient satisfaction survey. They're not always easy to get back, but we managed to get 10 back. We managed to get some positive feedback from that, so that was great. Next slide, please. In terms of the broader impact and change, I think we served our purpose. We wanted to focus on reducing the anticholinergic burden, reduce the use of high-dose medications. But I think in the process, I presented this to my 2 practices. What we've seen is there's a lot more awareness. Of course, we've targeted over 900 people with the local polypharmacy training with the 3 ICDs. So along with that, I feel that there's a lot more awareness around anticholinergics. And I often see this with GPs who are doing care home ward rounds on a weekly basis, and the use of those risperidones and haloperidols. They don't go on repeat so quickly now. They're being challenged on a weekly basis or on every review basis to make sure that when there is no need for them, we try and remove them as much as possible. Although this wasn't planned, I think it was quite nice to see a nice collaboration around a multidisciplinary team. So working with the learning disability key care coordinator, learning with the LD lead, safeguarding team, and also the pain management team. I think they were quite surprised that these are the kind of things they were referred, because usually it's a straightforward case of trying to support patients, but this was a much more complex patient. And also, I think it was a nice surprise for them that pharmacists were getting more involved in referring patients to the pain management service. Next slide, please. In terms of challenges, yeah, I think coordinating with 4 different practices in terms of trying to get a clinic together with patients wanting to attend at that time, it's not always easy. Some of the reviews, we had to do them over the phone, which is not ideal because you can't build that rapport the way you would, doing face-to-face. The other challenge, and initially the numbers were well over 75, and to try and break them down to 40, obviously, you feel guilty that you're not providing the same level of service. So I think as part of our next project is obviously trying to extend this further because we're raising awareness. The lessons we've learned, the project was quite complex, so be prepared that it's not going to be a straightforward one appointment. There's going to be multiple follow-ups, and also be prepared to work collaboratively with various different healthcare professionals. So having an awareness of a wider network and trying to work as part of an MDT is probably quite vital. And I think probably the last thing is probably be transparent with your patients. I think somebody's already mentioned earlier that patients feel that you're trying to save money for them. It's not the case at all. It's trying to understand them and make them aware of the risk medications can cause, and reviewing them regularly can only help minimize that risk. In terms of our next step, I think some of it we've done. So we've raised awareness around deep prescribing benefits. We managed to do that. Sustainability. So our aim is that now that the other pharmacists from the other practices have been involved, along with my other 2 pharmacists who are aware, we've done care home projects similarly. So we're hoping that there's a lot more awareness, and we're able to, make sure that we create this rather than audit. We create this as a quality improvement. So we're following it up as well as running researches on an annual basis. And training and knowledge sharing. Yeah, I think quite a bit it's been done with the local program, but if there are trainings still available, then I highly recommend the LS program, because it really highlights and gives you the tools to be able to go and prescribe without not relying on the lack of guidelines as such. Finally, I think in terms of the conclusion, sorry, next slide. Oh, I don't have one. Okay, that's fine. Thank you.
Thank you so much, Nixit. And it's great to see how the structured medication reviews are so holistic, that you're looking at the overall care for the patient, and actually your selection for people to review, people that were had over 3 admissions already identified to very complex cases, and you can see how much involvement is needed in some of those cases. So it's lovely to see your case studies and how much you've improved the lives of those people as well. So well done, Nixit. I'm going to open up now and hand over to Gillian. We're running a bit over, but if Gillian, 10 minutes for the main questions. Yep.
Yeah, that's fine. Thank you. So I'm Gillian. I'm from Bob ICB. I'm one of the medicine optimisation pharmacists there. And I'd just like to thank our first four presenters for doing such an excellent job at presenting your projects that you and your teams have been carrying out in practice. And I follow what Seema has said, in that there's been some really positive outcomes here, and not just for the project's intention. Often there's been outcomes that have been far outreaching, beyond what that scope initially was set at, and patients have definitely benefited as a result. And we have had a few questions in the chat, and Sonny has been frantically responding to the ones that were directed at him. But I did think it would be good just to have a chat about some of them, if that's all right, Sonny, because there were a few, and just so that we can discuss them. And if other people have any other questions, they can just come in. But the first one was around the protocols that you use for reducing and stopping antidepressants, because I know we've looked at that in our ICB before, and there's a whole raft of various recommendations and guidance, but there's nothing particularly formal as such. So what did you actually use to help you with those decisions?
So mainly the PHQ-9 was the baseline. So when we did the initial conversation with them, that's why we needed to gauge where they were at. If there was a high score with the PHQ-9, then certainly where their current state was, it probably would be wise to be tinkering with the dose or reducing. So anyone really above a moderate, so 10 and above, I would say you would really kind of go, okay, may not be the right time to do it, but certainly keep the door open if they wanted to come back at a later date. There wasn't any particular sort of, other guidelines, like I say. So Maudsley was a very good piece of book. So anyone who has read the Maudsley deprescribing guideline will know that. Anyone who hasn't, I'd always sort of guide them to that, because it really does give a good understanding of how withdrawal occurs, and you're then able to engage that with the patient, explain that to them, and get them prepared for anything. So certainly if they do hit a bump in the road, they obviously can they can be prepared for that. Brendan has his hand up, so you might want to come in.
Thanks, Annie. I just thought it was interesting, and to add the Maudsley deprescribing of antidepressants and a bit of publicity around specifically hyperbolic reductions came out in advance of us doing this project, and the team felt quite anxious, I think, about the big push for hyperbolic dose reductions, which is, if you reduce doses incrementally by a fixed percentage, and the tablet or the dose formulations don't lend themselves to be able to do that easily. So we did a bit of a deep dive into some of the literature, and had a frank discussion, and decided to follow a sort of fixed dose reduction for most patients, and if patients experienced difficulties, to then switch to that sort of hyperbolic reduction. And it's all the guidelines that we followed are the stopping antidepressants guidelines, which are available on the Royal College of Psychiatry's website.
Thank you. So did you actually have any patients that did relapse, or you had to, how many patients, what proportion of patients did you have to take a more delicate approach to, or had a problem once you started to reduce it?
Do you have the exact numbers, Brendan? That's the question. So I don't think I had a few that I personally dealt with that did have some relapses, and sometimes, again, like Brendan mentioned, they're switching them. I had switched a couple of patients to a liquid dose, and then did a slower taper with that, which helped to negate the withdrawal. And again, across the PCN, though, I don't know exactly the number that we could give to do that, but we were all clued up with the types of regimes to dip in and dip out. And like I said, the fundamental work around recognizing those then helped us tailor when we had the next review as to how we went forward beyond that.
And just quickly, what was your period between seeing the patient and your review? Did you have a set period of time?
Yeah. So 1 to 2 weeks would be the initial, and then it was 4 to 6, and then at 8 to 12. So we would sort of, depending on how good or bad it went, you could tailor it. And we actually ended up going more 4 months than the initial sort of 3. And if we did then need to do anything further, beyond the period of what we were measuring, we still did, but we didn't then count that in the results. So people did still potentially stop their medication, but it might have taken 6 months or 8 months down the road.
Okay, thank you very much. That's really helpful. In terms of the ACB work that was discussed, and we had 2 projects, and I'm not sure if Kavita's been able to stay on or whether she's had to drop off. But I think if those teams could share any tools that you used, somebody's asked if there was the education guide that Kavita you used for your team, if that could be shared with Mariana so it can be circulated around the group, other people might find that beneficial. But again, did you experience any patients that had setbacks when you started to deprescribe their anticholinergics or anything like that? Or was it quite straightforward in both of the projects, Sally and Kavita? Sorry.
Kavita, do you want to go first?
Yeah, I don't mind. So what we found, we reviewed these patients on a weekly basis. So we reviewed 27, but we started off with a handful, and then when we'd sort of complete the patient, we'd move on and take on more. So we had time to review them on a weekly basis. We were quite cautious with the tapering of the doses that we did. We did tend to go for a fixed dose regime because, it's just easier. At least the tablets or whatever you're reducing does come in standard sizes. We found that most of our patients were actually fine. There was only one patient that we actually had to restart an antidepressant on. But aside to that, out of the others, none of the other patients had any issues.
Thank you. Sally, anything from you?
Yeah, similar. So I think where possible, so largely when we were looking at the drugs that were involved, a lot of the ones with the bladder one's the solifenacin type medication with a high ACB score and often not terribly effective. So we found it really helpful to talk about, firstly, how well were they working in the first place? And then you're sort of pushing against an open door. If the drugs aren't working and they've got potential for harm, then it's much easier to approach it in that way. And often what we were doing was replacing with a drug with a lower ACB score, so mirabegron, for example, in bladder patients. I think the tricky bits were perhaps the tricyclics, where they may have been initiated for neuropathic pain, but actually were being used as a sleep aid. They were a lot harder to come off, but it's all in the cell, I think, and that skillful shared decision making, which we know that clinical pharmacists are great at.
Yeah, thank you. And one more for Kavita. Your project was based around care home patients. I was just wondering if there was any idea or whether you thought it could be done in non-care home patients, because obviously people are taking anticholinergics in all situations. And I just wondered if you've considered, or you gave your explanation why you've chosen that group, but is it something that could be matched in that other population, do you think?
Yeah, it certainly can be matched in that other population. It's very transferable. Like I said, we just went for that particular group because they get less attention. But we do have one of our surgeries who is actually currently working on non-care home patients as well.
Fabulous. Thank you. So it's replicable in different situations. Hi, Nixit, comment, please.
Just talking about care homes, I mean, the Stop Frail toolkit is actually ideal for care home residents, elderly, may have a reduced life expectancy. They have got a lot of information which can help with deprescribing medications.
Thank you. And last question for you, Nixit, really. I think your project was the only one that talked about stratifying patients, which I thought was, you actually targeted the ones at highest risk, whereas I don't know whether the other projects you did that or whether you just picked a cohort and just reviewed the people that responded. But you mentioned the EMIS Enterprise tool. I'm assuming that is a risk stratification tool that you use in your.
So yeah, it's called the Eclipse tool, which is commissioned by a local ICB. So we use that to try and identify patients from that, and then narrow it further down with patients who are most at risk. So in terms of the number of medicines they were taking, number of hospital admissions, and where there was more potential where we could actually add value.
Thank you. So just in case other people are not aware, across Frimley and Bob, we also have risk stratification tools that practices can use. So, you know, if you want to pick out those patients that are at most risk, that are having the most hospital admissions, once you've got your cohort, you can actually help to, try and pick out those highest risk patients. I think I've covered most of the questions that were in the chat. Like I said, the guys have been answering the questions that have been posted, Brilliant. But I think that gave a bit of a summary of the kind of things that were being asked. Please continue to put things into the chat if something's come up in response to those first four projects. And I'm sure we can get to the presenters and ask them if there's any further information that we require at a later date. So thank you.
Thank you, Jill, and thank you for summarising the questions so nicely. And yeah, presenters, please do answer any questions in the chat, in the Q&A section that haven't been covered. So moving on to our next set of 4 quality improvement initiatives. These have all focused on using materials to support patients be better prepared for the structured medication reviews. So the first one I'm going to pass over to Charlotte, and who's looked at reducing polypharmacy in patients where English isn't their second language.
Lovely, thank you very much. So yes, like the, if we can do next slide, please. So yes, like the project said, we're looking at reducing polypharmacy in patients whereby English is a second language. And this was a project that, although I'm presenting, was a complete team effort from our PCN, so Reading Holybrook PCN in Bob ICB, and it was through a team of 3 clinical pharmacists and a pharmacy technician that contributed to this project. Next slide, please. So we were really keen to get involved in this project because we have a large cohort of patients who have high polypharmacy. We are in an area in Reading called Whitley, which is one of the most deprived wards in Reading. So we've got a lot of social deprivation, and as part of our patient cohort, around about 25% don't read or write in English. So we have a lot of language barriers that we need to be able to overcome. And it's a population that we have looked at that's a really seldom heard from population, where we get low engagement for general routine reviews and just general access into the practice. So we wanted to improve that with this project. Next slide, please. So what we did is we presented our kind of project pitch at one of our local internal meetings to try and engage all of the clinical team to be part of this, so that it wasn't just clinical pharmacist-led, but we tried to get all the clinicians on board. We looked at our target cohort, which was looking at patients with polypharmacy where English was a second language, and we further reduced this by looking at patients with the in the highest risk groups as part of the patient segmentation, which was mentioned earlier. So this is one of the things we tried to do to make the cohort smaller and more manageable initially. So we focused on the highest risk groups, which are PNG group 10 and 11, to try and reduce down our cohort. Next slide, please. So as part of the project, we managed to find a cohort of around 70 patients, and we tried to engage them through various means. Telephone call was our preferred way to try and contact patients to get the quickest response. That was generally with the aid of an interpreter or through speaking to a family member with the patient's consent. We also tried sending text messages, trying to get those into patients' first language, and with the attachments from the HIN project, looking at the SMR resources, particularly the invitation letter in a patient's language of choice. And for any patients that we couldn't get hold of through these means, we posted the invitation letter with a copy of all the resources so that the patients could adequately prepare for their SMR. We tried to make these face-to-face in the practice where possible, but because of our cohort of patients, they had various challenges getting into the practice due to travel costs, carer availability, and trying to fit into the clinics proved a little bit of a challenge. So some of these were converted into telephone calls, which wasn't ideal, but it was a way to still get the patients engaged. On the back of this, we managed to get 52 patients booked in for their SMRs with the pharmacy team. And we had some really good feedback from the patients as a result of this. Next slide, please. So the patient invitation letter, which we sent out via post and also attached to the AccuRx message, was the most well-received resource when getting patients to be engaged. We had really positive feedback from patients about receiving any letters in their first language, which is something they haven't had before. So that really got people to start to want to come in and start to attend these appointments, which was great. The clinical team, on the back of this good patient feedback, they were becoming more engaged with the project, and they were actively signposting patients that they spoke to during clinics to the pharmacy team for an SMR as well, to try and improve our numbers of patients we could contact. We were involved with de-prescribing a lot of medications. We improved patient safety and our prescribing practices in general by being able to engage with these patients and have these conversations. We improved access, that we had this cohort of patients that we hadn't seen in a very long time for some of them, despite numerous attempts to engage them and short dating their prescriptions. We actually managed to get them to come in, and then they were keen to get involved in other services by coming in. So we got SMRs booked, we got other long-term conditions booked as a result of this project. So it all came together really nicely. General reduction in polypharmacy, we reduced a lot of medications through the process, and overall the biggest win was this more engaged and empowered cohort. Next slide, please. So the biggest challenge was trying to get hold of these patients. So post seemed to be the most effective way for us to get in touch with them. Slightly more expensive, but it was the way that actually worked best for our patients, and we had printouts of the engagement tools at reception as well for any patients that did happen to be in the practice. For those that did attend for their SMR, there was a noted increase in their engagement. They attended more regularly for their LTC reviews, so patients with diabetes and other long-term conditions attended much more regularly as a result of this project, and we found them engaging in other things, like I mentioned, with cytology and other areas of their care as well as a result of this project. Next slide, please. So in terms of what we're continuing to do and what our next steps are, so we're using the HIN resources, particularly the invitation letter, to encourage more patients to attend. We're doing this as part of our routine recalls now, so not just for SMRs, but for any long-term condition recall where English is noted to be a second language. We're using this resource to encourage patients to come in for their medication review as part of their recall, and using this as a tool to help them engage with that process. We've got the resources shared in the waiting rooms, we've got them on our electronic TVs, and we've got copies on our website. And we're trying to engage with our local PPG to get some of this spread throughout their local communities, so through mosques, churches and temples, to try and share the resources out to a wider audience to get more people involved in the project and try to reduce polypharmacy for a larger cohort. That's great. Thank you very much.
Thank you, Charlotte. Oh, that's a great piece of work, and it's you've really understood your population and your population needs and tailored interventions specifically to address the challenges. And again, your project's shown these great secondary benefits about how that engagement with the SMR has led on to wider health benefits for the patient. So well done with that one. Moving on to Sally again for your second project, Sally. Again, Sally's used the Me and My Medicines resources, and is just going to describe the impact that's had.
Thanks, Seema. Just timing that. Charlotte, your project was phenomenal. So I'm going to defer to Charlotte. That was great. So for our second project in Berkshire Primary Care, again, Emily, my colleague who's on a plane, led on this. And what we tried to do within the Bracknell District Primary Care Network, which is another 4 practices, was assess whether allowing patients to prepare through using the Me and My Medicines resources before the SMR, whether there was an improvement in patient satisfaction in how they viewed the SMR. And whilst we've been doing structured medication reviews for a considerable amount of time, and we are all having to make tough decisions about how we use our clinical pharmacy professional resources, we're mindful in our team that we could always do better. And one way of doing that is that we help prepare our patients so that they get more out of the SMRs than if we're just cold calling patients. So we had two distinct cohorts of patients, about 50 patients in each cohort. One who followed the traditional route of an SMR with no pre-information, and the second cohort who received the Me and My Medicines charter information up to a month before their appointment with a clinical pharmacist for a structured medication review. Next slide, please. In terms of the outcomes that we measured, we used the CPPE standard patient satisfaction questionnaire, and it's quite difficult to see a distinct change, which is why I haven't shared a graph on here. But there is a definite shift if you look at the trends, in that there's more ratings in the excellent and very good than in the sort of good and fair and poor. So there's a definite shift towards higher quality, or sorry, greater patient satisfaction in cohort 2 than there is in cohort 1. I think, as always, it's the words that the patients add to the PSQs, which are the bits that really are our reason for doing this. And that's that they felt the SMR was caring, very professional, and they felt that they'd been listened to, particularly around thoughts and beliefs around medicines. So we hope to show, and we did show, although I'm not sure how statistically significant the results are, that there was an improved confidence and engagement in patients and a shift in patient satisfaction. I have to say that whenever we've done patient satisfaction questionnaires, pharmacists generally score extremely highly because we are patient-centered and patient-focused. So it's quite hard to improve on generally good, but better was where we were looking for. Next slide, please. So what went well? Using the resources certainly helped improve things, and that team working where we had actually we have a pharmacy care coordinator linked with our team who was doing the sending out of the pre-work. As ever, there's challenges in these sort of short-term QI projects where we're trying to do a lot of work with a short deadline. Our PSQ response rate was lower than we'd hoped for, and I think fundamentally that's because we were using a digital first AccuRx response into Microsoft Forms, and perhaps the cohorts that we're generally doing SMRs on are not that digitally enabled, as a broad statement. And the second thing that might have contributed to lower DNA rates of the SMRs was that the winter months when we were doing this project. And we're always looking to improve on those outcomes. Final slide, please. Next steps, and I think it's how we turn a QI project into business as usual, which is always a challenge. And so we now have a sort of SOP that when we're booking patients in for an SMR, they get this automatically. When I was reviewing the notes, I wondered actually if we'd used the best of the patient tools, and perhaps looking at some of the other resources in the Me and My Medicines and approaching it with a different tool like the invitation letters or the one where patients can scribble on it and have prompt questions may have got a better uptake. And then how we spread this and continue to make sure that we are always improving our SMRs and our patient engagement. Thanks very much.
Thank you, Sally. And it's great that you've incorporated this into your business as usual, actually, because it's one thing to show an improvement in a project time frame, but actually to make that sustainable is not easy. So well done on doing that. If we go on to the next one, we've got Sarah Hibbert and Sarah Morrish, who've done a project on improving access to SMRs in seldom heard communities as well. So we just hear about their work now.
Yeah, hello there. So I'm Sarah. I'm one half of the two Sarahs who conducted this Improving Access to SMRs in Seldom Heard Communities project. We both work for Caritas PCM, which comes under the Bedfordshire, Luton and Milton Keynes ICB. We've job shared in a variety of roles over many years, and we come as a pair. We've worked in care homes for the elderly, in our local area with everything to do with medicines. And before that, we'd been in community pharmacy for over 20 years. But yeah, enough about that. Let's get on with our project. Next slide. Thanks.
Hi, so I'm Sarah Morris, the other half of your Sarah double act for today. Our project was undertaken to explore ways of improving access to SMRs in seldom heard communities. So why did we deliver this particular project? Well, 3 out of the 4 GP practices in Caritas PCN are defined as deep end practices who serve a higher than average number of patients that are the most socially economic deprived. Charlotte alluded to this cohort of patients earlier in her presentation. We know that people are living longer with multiple health conditions, often contributing to an increasing burden of medication. Previous published research has also shown that evidence that there are people in areas of higher deprivation and from Black, Asian and minority ethnic communities are more likely to be taking multiple medicines and experience overprescribing, increasing the risk of harm from medicines. We wanted to utilize tools and resources at our disposal to encourage uptake of SMRs in these patients and measure the outcomes from the reviews with the aim to improve both. Next slide, please.
So how did we do it? Well, we used the, the Eclipse risk stratification tool to identify the patients who had the highest deprivation score. They were at least 75 years old and they had 10 or more medicines on a repeat. We gave the list of the suitable patients to the care coordinators who contacted them to book a review. They checked if the patient needed support for the review due to language, hearing, cognition issues, and who they would like to provide this, obviously making sure they would be available for the appointment. The care coordinators sent out the leaflets reviewing your medicines and are your medicines working for you, the HIN leaflets, and in the patient's preferred format and language via email or post, basically just to help prepare patients to prepare. The care coordinators also contacted the patients the day before their appointment to remind them of the review. And as pharmacists, the project allowed us time to prepare thoroughly beforehand. So to identify areas that it would be helpful to cover during the review, which is something that we don't normally get time for as a rule. All of the reviews were carried out over the phone. The details are written up fully in the patient's records, updated repeats, appointments, follow-up appointments booked if need be, other clinicians involved as appropriate. And we also completed the safely stopping your medicines leaflet for any medicines that we had stopped, and the care coordinator sent those out to the patients. Next slide, please.
So what did we achieve? Well, we were able to complete an SMR for 100% of the patients that we'd identified using the risk stratification tool. In total, 26 medicines were discontinued from repeats, and 25% of our patients had their ACB score reduced as a result of the SMR. The satisfaction survey data shown on the slide speaks for itself, but I wanted to share a couple of the quotes we received in our feedback. So from one of our patient representatives, they said this was mum's first review and the leaflet was straightforward. It helped us think about her medicines before the consultation, which was really useful for the pharmacist. And a quote from one of our care coordinators who actually rang round to each patient or their representative after the SMR to gain the feedback. That's how we gathered our feedback on this project. The care coordinator said, during follow-up for feedback, many patients shared positive comments about the leaflets, saying that it helped them understand the purpose of the appointment and supported them during the consultation. Next slide, please.
So one of the main challenges confirmed by the project is supporting patients for whom English is not their first language. Having the leaflets available in the different languages was appreciated. They allow patients to access the information themselves rather than relying on a family member to translate or explain it. Of the reviews that required a translator, most used a family member rather than a translation service, and this proved to be more successful, because having the translator alongside the patient enabled them to read the medication names from the packs, which the remote translator couldn't do. And as I'm sure we're aware, a lot of the people who struggle with English, it's not just spoken English, but reading it too. And also working with a family member alongside the person who was involved and invested in their care was a definite advantage. The other main challenge is really how we move on from the project. How can we resource medicine reviews carried out in this way? Because the funding for the project allowed pharmacists time to prepare prior, and for the care coordinators to book appointments, call patients the day before, to remind them to send the information before and after. So that all takes time. The resources and the feedback, the results and feedback from the reviews undertaken for this project showed that carrying them out in this way was very effective, but the feasibility of resourcing such a method going forward remains to be a challenge. Next slide, please.
So what are the opportunities for increasing SMR engagement in this population? Well, they all came from the lessons learned that Sarah's just explained. We feel that using the resource leaflets helps patients and their representatives understand the reason for the appointment and engage in reviews. And as Sarah said, investing with care coordinators using their time in booking appointments, reminding before the appointments seemed to be very successful, and sending out the pre and post SMR information supported 100% appointment utilisation, which we'll know if you cold call people for SMR reviews, you don't always get 100% appointment utilisation. This allows the pharmacist preparation time to be used effectively. There's no wasted time in preparing for reviews where the patient is not contactable. Thanks for listening to our presentation, and obviously we'll take any questions you have later.
Thank you, Sarah and it's really great to see how you've used care coordinators within your project and actually involved the family and carers, which has really sort of helped to get the most out of those SMRs. We're going to move on to our next project. Please can presenters answer some of the questions that have come up in the chat themselves, because we may not have as long for the question and answer session at the end. But if we just go on now to Brendan, which is our final quality improvement initiative. And Brendan will again talk about a public behaviour change initiative that his team have led in Nora PCN.
Thank you, Seema. I'll try and keep it brief for time. My name is Brendan Jiang. Good afternoon, everyone. I'm the Senior Clinical Pharmacist at North Oxfordshire Rural Alliance PCN. Now, most clinicians, I think, who've done medication reviews will recognise the patient at a medication review who asks, what's the point of this? I take the medicines the doctor prescribes me. Now, despite years of delivering structured medication reviews, many patients still aren't clear on their purpose and may not be prepared adequately to get the most out of them. Our team of 9 pharmacists and a pharmacy technician hoped to improve engagement and shared decision-making through the use of the Health Innovation Network SMR invitation materials. Next slide, please. So polypharmacy is strongly associated with increased medication harm, particularly in older adults, as age-related physiological changes can affect drug metabolism and increase the risk of adverse drug reactions. This risk is further compounded by the presence of multiple chronic health conditions, and we wanted to make sure that we targeted these patients across our PCN. So we looked at patients who were taking 10 or more medicines using the EPACT2 polypharmacy dashboard, then cross-reference those patients with our clinical system. We randomized the patients into a control group who received care as usual, and an intervention group that would receive the Me and My Medicines Charter, the Stopping Medication Guide, and the HIN invitation to an SMR. Pharmacists conducted an SMR, 30 minutes each, and they were face-to-face reviews or by phone. And we used a quality of life survey, the EQ5D5L survey, both pre-SMR and post-SMR to assess impact. We asked patients as well for their thoughts using a patient survey. So the primary outcomes are there. Next slide, please. There were 120 patients who were invited. The intervention group had slightly higher responses, attendance, and completion rates. 37 meds were stopped in total across all 120, 16 in the intervention arm, 21 in the control. So interestingly, more patients stopped medicines in the control group, but the numbers were quite small. The quality of life scores didn't really show any significant change. Response rates were low, results were variable, and most of the other results were not really significant. Feedback was mixed. Some patients engaged really well with the materials, but others said that they didn't even receive them or read them. So, quotes are on the page. I found this medicine review very useful, reassured that my medicines were necessary and at the correct level now. But some people said, I got it, but I never even looked at it. Next slide, please. So to quote or rather misquote the Jedi Master Yoda, patience you must have, my young Padawan. We initially targeted patients trying to take taking 15 meds or more. There were 63 eligible patients across our 50,000 patient PCN. But when we cross-referenced that with EMIS and in hindsight, looking at it, that we did a 3-month project. So really a quarter of those patients didn't give us many to review. So we either had to pull those medication reviews forward or review patients who'd already had their medication review this year. And we decided instead to pivot and drop the threshold to 10 or more meds so we could capture sufficient patients to a medication review. The learning point is that timing matters as much as targeting when you are building a quality improvement project. Next slide, please. Similar to Sally's project, I think, seasonal interference. So we ran our project over the Christmas period, and it was affected by illness, staff leave, and patients DNAing. It was quite difficult to manage and could well have affected the response rates that we received. But these kinds of seasonal and staffing pressures should be accounted for when you're planning a QI project. Interestingly, one of the patients responded that the resources that they received, they said, I probably binned it with all the Black Friday stuff, which was disappointing and leads into the next point. Next slide, please. So I don't know if anyone's heard of the rule of 7, and that's a marketing theory that people need to hear a message at least 7 times before they act. I think in healthcare, sometimes we hope that one letter will do, and we need to consider a layered, repeated messaging strategy to help support behavioral change. So that patient who said that they binned this stuff with all their Black Friday stuff, great materials won't have any impact if patients don't see them, they don't remember them, they don't engage with them. So in future projects, next slide, please. Future projects, we're going to think about, can we do a multifaceted way of trying to get that message across? And I think some other projects have used that with using the waiting room scheme as well as screen, as well as other options. So what's changed? We've embedded the HIN language into our standard SMR invites. We're exploring using SMS follow-ups and phone reminders for those patients who don't engage electronically to try and boost engagement. We discovered that there is EQ 5D5L SNOMED codes in EMIS, and that opens the door to building a simple, consistent data template for easy data entry. And I think, going forward, we just want to build on what worked for us: clearer communication, better timing, smarter data capture, and maybe have more targeted at some of those higher risk cohorts like Nixit referred to earlier. So happy to answer any questions. Thank you very much.
Thank you, Brendan. And it's great that you sort of recognise that it's really important to understand behaviours, because sometimes you can think sending out a leaflet works, but actually it doesn't. And I love that rule of 7. I hadn't heard of that before, so thank you for explaining that. I'm going to hand over to Sundar. We haven't got much time, Sundar, but if there's top 1 or 2 questions you want to focus in on.
Yes, I can see that most of the questions have actually been answered, but really I think it's more of a general kind of overview comment really from me. I think it's been absolutely lovely to hear the you know, that the work that's been done with these 8 fantastic quality improvement projects across our region. And, you know, really like that we finished off with Brendan, where he's clarified that actually there is, all of them, to be honest, all the projects have clarified there is a need for us to engage with our patients, not, you know, not just once, twice, multiple times, but also how we engage with them. And, you know, these projects have, you know, clarified the need to use resources, or the use of resources can make that easier for us. So that was one of the things that I just wanted to share. And, you know, people sharing that through their projects, there were some unintended consequences, that some of these projects grew arms and legs, and, you know, projects never really die. We know that. So actually, you know, things to think about, and maybe these are the questions that we take away with us, is how are we going to roll these projects out? How do we adapt them for other patient cohorts, other groups of patients? How do we use these resources for other people in our population? I'm going to hand over back to you, Seema, because I'm conscious of time.
Oh, thank you very much, Sindis. And yes, I'd reiterate that there's like absolutely great projects there. I know some are continuing, some have got potential to continue, and we're hoping that they'll be spread further. If anybody would like to ask any additional questions, if you can channel them through to Mariana, and we'll get them to the relevant project leads. And I'm sure they'll be happy to answer any questions. And we've got a feedback survey. If you could kindly fill that in, we'd be very grateful. We'll pop that QR code in the chat. And just to finish up, we're going to be sharing the slides and the recording and actually the posters, and we're going to produce a summative report as well. Both will be available on our website when they're ready. There's a final impact report being done by the Health Innovation South London. That'll be out in September. That's for the programme overall, so we'll share that as well. I know our ICBs are going to be continuing a lot of the polypharmacy work, even though this programme is ended now, but a lot of the COPs have now been embedded into the ICB training schedules already. So those will be ongoing, which will be a great legacy from the programme. And just to signpost you to this document that's been published, Claire Howard has produced this, and it's a great one on the mechanics of tackling overprescribing, which you may all find useful. So just to end, thank you so much for attending. Thank you very much to all our presenters and everybody who's been involved in this programme throughout the 3 years. We're very grateful, and it's contributed to making this programme a success. So thank you very much.